Shilpa can put it live streaming.
Okay. Yes, she has done it.
Welcome. Good evening, everyone. I welcome to you all today's program, 9th online weekly academic program of in the name of Pudukkottai Budan, organized by ISA Pudukkottai City Branch. At the outset, I welcome and invite our Secretary, Dr. M. Periyasamy, to welcome everyone. Dr. Periyasamy, please.
Yes, sir. Yes, sir. Thank you, sir. Thank you. So screen is not coming.
Wait, sir. Niveta ma'am is trying to share. Yeah, it is working, Dr. Niveta.
Okay, ma'am.
You can change the slide.
Okay, ma'am.
Change the slide.
Is that
Yeah, it's working. Perfect. Like this,
Okay.
only you have to share the screen.
okay?
I'll stop sharing.
Okay.
Periyaswamy sir, yeah, now you can share this.
Okay, madam. Okay, madam. Madam, it's not sharing.
Periyasamy, you have to share.
Yes, sir.
Share screen regularly you are doing, then what?
Okay. Wait a minute. Wait.
I think we are having drishti because 64 have entered.
These all small itches.
Dr. Periyasamy, you
Yes,
can
sir. Yes, sir. Coming.
without us sharing. This is the first time it is happening. Even in the beginning, it was not like that.
Am I audible?
Yes.
So good evening to all. It is very nice to see you all in every week in the session of Pudukkottai Society of Anesthesiologists conducting Pudukkottai Budan on every Wednesday. So this is the 9th scheduled meeting of Pudukkottai Budan online CME program. I once again welcome you all. For this session, we are having our state president, Dr. S. Kumar, person, Madurai. I welcome you, sir. And as a speaker, we are having 3 eminent speakers from Coimbatore Medical College. One is Madam Dr. Narmada, Associate Professor, Coimbatore Medical College. Madam is going to talk about anesthesia implication of pacemaker. Welcome you, madam.
Thank you, sir. Good evening, sir.
Good evening, madam. Next, a person, Dr. Chandrakala, Assistant Professor, Coimbatore Medical College. Madam is going to deliver artificial pacemaker for wanted horse. Welcome you, madam.
Good evening, sir.
Good evening. Another person, Dr. Niveta, a resident of Coimbatore Medical College. Madam is going to talk about normal conduction, cardiac conduction.
Good evening,
Good evening, sir. Good evening. Good evening, and welcome you all, madam and sir.
Thank you, sir. Thank you.
These are the topics we already covered in this Pudukkottai Budan online CME program. This is the 9th meeting of this program. More than 30 topics have been covered by eminent speakers from all over the country. An important event in our anesthesia society, national society. Last week, we opened a national registered office at Chennai by our national president Venkatagiri and secretary and all other eminent persons from all over the country. The office is named as Dr. Balakrishnan. You know all about his academic tenure. He is a known senior most anesthesiologist and professor of our state, and it is a great honor to us to having his name in this register office at Chennai. And this is the details for registering credit points. The Tamil Nadu Medical Council credit points. The most important thing is you have to send the details to isapudukkottai@yahoo.com with your mail ID, phone number, and 100 rupees to the mentioned bank number, the SBI number. All details are here. You can note it down. And today we are going to talk about pacemaker. This is a small note about pacemaker. Pacemaker is the electronic booster of inefficient heart, electrically charged inbuilt tiny heart. Actually, this is tiny heart for needy persons. Quietly kickstart the heart. Quantum of life saved by the RAN. Heart loves the pacemaker, but it fails and fatigue to generate. Yes. Sir, and our president, Dr. Suresh Kumar sir, President Dr. David for their continuous hard-working effort and support to conduct this successful program every week without any delay and break. Thank you, sir. Thank you, and once again welcome you on behalf of ISA Pudukkottai. Thank you very much.
Thank you, Dr. Periyaswamy.
Thank you, sir.
Thank you. Dear Secretary, Pudukkottai ISA City Branch, respected academic chairman of our branch, Dr. A.L. Meenakshi Sundaram sir, respected Dr. S. Kumar, President, ISA City Branch, who has consented to be the chairperson of this weekly webinar. We are very happy and we are very privileged for your participation, sir. Today's seminar is very special because it is an all-women seminar. I welcome on behalf of ISA Pudukkottai City Branch, Dr. Narmada, Dr. Chandrakala, Dr. Niveda from Coimbatore Medical College, who has consented to be the speakers in the topic of pacemaker. Today I read a Tirukkural in the morning. இதனை இதனால் இவன் முடிக்கும் என்றாய்ந்து அதனை அவன் கண் விடல். I thought about our academic chairman only. After reading this Quran, the person, the face came is Yailam sir, because he is wonderfully and very successfully running this show. We are very happy and we are thankful at this moment. And once again, I welcome you all. One interesting thing I read I just went through the web about pacemakers. So many people are contributed in the invention and discovery, but two interesting things are there. The first patient, pacemaker, he had 26 attempts of pacemaker in his life. And the first surgeon who implanted him and the inventor of the pacemaker died even before this person died. So he lived up to 86 years with a pacemaker. That is one good thing. And another thing, one pacemaker was recorded in the Guinness World Book of Records. It was in a patient Stephen Reed for 37 years and 251 days, which was the counting date that from last year in 2021. That pacemaker was still functioning. So these are two interesting facts I just wanted to mention. Today's session will be very practical, and I request all the delegates to make use of it in the attending the webinar in full steam, and kindly, as requested by our academic chairman, please log in with your name and credentials so that it will be useful for us to give your credit hours. Thank you. I hand over the proceedings to our academic chairman, Dr. A.L.M. sir. Thank you, sir. Thank you.
Thanks, President Dr. Suresh Kumar. Today I am really delighted for so many reasons. First, the President ISA Tamil Nadu has consented to be the chairperson for our webinar. And usually, if a webinar, when there is a lot of webinar, if 50 persons are attending, that is a good number. But today, even before the beginning of session, we have 82 members. So really, it is a good day. And the Pudukkottai Buddhan has picked up its pace. That is the reason why pacemaker has come in, I think. Because of that good pace, rapid momentum is there. So I congratulate the chairperson and the faculty, 3 faculty, because they could attract the crowd. As that Tirukkural pointed out, I have also done the same thing. I have handed over the webinar to Dr. Narmata. She was kind enough to arrange 2 people. And see, our President Dr. Suresh Kumar has pointed out, it is an all-women show. But even before that, we had JSS Mysore. When they were talking about neuromuscular monitoring, it was 3 lady doctors. And now these Mupperum Deviyar are going to perform about the pacemaker. And we label ladies as Shakti. So I think the pacemaker, really the Shakti behind the heart, will be dealt in a very good way by these 3 people. I want to say about these 3 people. One, Dr. Narmada, the associate professor, she is a gynecologist. See, usually people will read anesthesia and they will switch over to surgery. But this madam, she has done her OG and she has come to anesthesiology. And so definitely this obstetrician will not be nervous. This obstetrician will not be afraid of anything. And she can better manage all the things, including a neonatal resuscitation. She resides in Coimbatore, and she is interested in performing ultrasound guided nerve block and pain relief in addition to obstetrics. So she is the right person to perform a painless epidural. And see, she is the junior most professor in Coimbatore. Why I am telling that, the assistant professor, Dr. Chandrakala, was also the junior most assistant professor who has graduated in 2020. And in 22, she is delivering a lecture. And Dr. Niveta is also a postgraduate. So what I infer, people are having a lot of enthusiasm and energy when they are junior, and the seniors are in frustrated mode. So in Coimbatore Medical College, I congratulate all these 3 who have come to the webinar with a lot of enthusiasm. And Dr. Niveda, even though she is a postgraduate, she has evinced keen interest in this symposium, and they have rightly selected the topic as a pacemaker. And to cap it all, then only the problem comes, then who will be the chairperson for this? Obviously, it is Dr. S. Kumar, who is one of the handsome anesthesiologists in not only in the Tamil Nadu community, it is in the national community. He is always with a smiling face, the smiling king, Dr. Kumar. Even before he becomes the president of ISA Tamil Nadu, he is known for his ability in cardiac anesthesia. That man is fully devoted, and whenever I am having cardiology doubt, not a cardiac anesthesia doubt, cardiology doubt, I used to consult him only. In that way, he is a telemedicine teacher. Even a few days back, we were discussing about a stress ECG. So he is the right person to talk on. cardiac anesthesia, and she is the fit person to be the chairperson for this pacemaker symposium. And I am again very happy. We will be touching this 100 even before the session. Now it is 88. So because of this 88, I congratulate the Pudukkottai ISA President, Secretary Dr. Periyasamy, David Treasurer, and all the members, faculty, chairperson who have made it possible. Really, we are delighted. Now I am handing over the session to the chairperson, Dr. Kumar. Sir, please take it over. It is yours.
Thank you, sir. Thank you very much.
Thank you, sir, for this introduction.
Respected Academic Chairman, Dr. A.L. Meenakshundra, sir. President ISA Pudukkottai, Dr. Suresh Kumar. Secretary ISA Pudukkottai, Dr. Periyasamy. Treasurer ISA Pudukkottai, Dr. David. Members of ISA Tamil Nadu. And today's Sir Sonamari, three speakers of today's event. Madam Dr. Narmata, Dr. Chandrakala, and Dr. Niveta. Members of ISA, my dear friends, a very good evening to everyone. At the outset, I would like to thank my teacher and one of my mentors, Academic Chairman Dr. A.L. Meenakshundra, sir. When I was doing CRRI, he was doing the second year MD postgraduate at Tanjavur Medical College. From then onwards, I have seen the same enthusiasm, and now it is more than that enthusiasm in academics. Thank you very much, sir, for the invite. I also thank Pudukkottai ISA for all the efforts to conduct this weekly webinar program in a very successful manner. I really congratulate the entire team headed by Dr. Suresh and Dr. Periyasamy. It is really well appreciated and well received by all the members of ISA throughout the country. Thank you very much. With this, we will move on to the topic. As sir was telling, it is pacemaker and anesthesia. We have three interesting speakers. And the use of you all know that the use of pacemaker is increasing worldwide. And more than that, the use of the patients with pacemaker landing for surgery also increasing. This obviously poses a great challenge to the anesthesiologist to take up the patient with the pacemaker and ICDs, that is implantable cardiovascular defibrillators. So for facing those challenges, we need to be updated and we need to know the basics as well as. For that, we have three excellent speakers from Coimbatore Medical College. I am from Tanjavur, but Coimbatore is well connected to me because I am the son-in-law of Coimbatore. So from there, I have three good speakers under the leadership of Dr. Narmata ma'am. So for the first topic, we'll invite Dr. Niveta to talk about the conduction system of the heart. Before that, one kind request to all the members who are attending this webinar, please post your questions on the chat box. Thereby, we can have the very good discussion, and you can also share your experiences, and we can have a very good discussion and take home messages from all of you. With this, I invite the first speaker, Dr. Niveta, to proceed with your talk. Thank you.
Thank you, sir. Good evening, sir. Good evening, everyone. This is Dr. Niveta, final year postgraduate from Coimbatore Medical College. I am here to present on normal conduction system of heart.
Moving on to the topic proper.
Moving on to the topic proper.
Conduction system of heart.
Yeah, please proceed.
Heart refers to a group of specialized cardiac muscle that spontaneously form impulses and transmit it to myocardium to initiate contraction. Conduction system of heart includes sinoatrial node, atrioventricular node, atrioventricular bundle of His, left and right bundle of His, and subendocardial Purkinje fibers. component is sinoatrial node. It is also known as node of cake flake, small horseshoe-shaped mass having a specialized myocardial tissue situated in the wall of the right atrium in the upper part of the sulcus terminalis, just below the opening of SVC. It is also known as the pacemaker of the heart. It generates impulse at an own rate of 70 per minute. It initiates heart contraction and it produces the heartbeat. The rate of impulse generation is controlled by autonomous system. Sympathetic system increases the SA nodal firing and it increases the heart rate, and parasympathetic system decreases the SA nodal firing and heart rate decreases. Once the impulse starts, it starts from superior to inferior in the atrium and it forces the blood towards the ventricle. At the same time, impulse is carried to the atrioventricular node and there will be a delay of 120 milliseconds for completely emptying the atrium. Atrioventricular node, it is also known as node of Vera. Node, it is located in the right atrium near the junction of intraventricular septum near the opening of coronary sinus. Connect cardiac impulses to the ventricle by atrioventricular bundle. Electrical impulses spread across the atria and converges at the AV node, and there will be a delay of 120 milliseconds. Wave of excitation pass from the AV node to the atrial bundle, and these differences between SA node and the AV node. It is a small mass of tissue in right atrium, and it is a small mass of tissue in the right atrium situated near the opening of IVC. And contrast to that, AV node is situated in the opening of coronary sinus, and SA node is long and flattened and ellipsoidal in shape, and AV node is short, half oval in shape, and SA node will generate cardiac impulses, and AV node will relay the cardiac impulses generated by the SA node and interface them. If it fires, it will fire at a rate of 200 beats per minute, and if an AV node fire on its own, it will fire at 40 to 60 beats per minute. SA node will transmit the cardiac impulses directly to the right and the left atrium. AV node transmit the cardiac impulses to the right and the left ventricle to the branches and terminal strands of bundle of His. SA node is a pacemaker, both a pacemaker of the heart, and SA node is regulated by autonomic nervous system, and AV node is regulated by the SA node. Bundle of it begins from the AV node and crosses the AV ring and runs along the inferior part of the membranous part of the intraventricular septum, where it divides into the right and left branches, extend interiorly intraventricular septum and superiorly to the walls of the ventricles. It is a fibrous framework that separates the muscles of the ventricles.
Dr. Niveta?
Yeah, I think she has lost the internet connection.
We can go to the next topic till she's getting connected. Yeah, she's losing connection.
Hello, sir. Am I audible?
Yes, but your voice is breaking.
Voice is breaking. Slides also not visible.
I think, madam, you can check your connection. Chairperson, if you are willing, we can move to the next topic so that madam can check.
No issue, sir. No issue. No problem. Niveta, you wanted to continue or you can wait?
Sir, is my slides visible, sir?
Not visible. Not visible. Can you please share again?
Yes, sir. I will share it again.
Yeah.
Is it visible?
Yes.
Yeah, please. Please go again.
Okay. Bundle of His, it begins from the AV node and crosses the AV ring and runs along the inferior part of the membranous part, intraventricular septum, divides into right, left, and it extends inferiorly along the intraventricular septum and superiorly to the lateral wall of the ventricle. Fibrous framework that connects the muscles of atria to the muscles of ventricle. is the only mean of conduction from atria to ventricle. It is a continuation of specialized tissue of AV node that transmits impulse from AV node to Purkinje fibers of the ventricle. Right bundle branch, it conducts impulse to the Purkinje fibers of the right ventricle, and left bundle branch, it conducts the impulse to the Purkinje fibers of the left ventricle. Left and right branches of bundle of His. Right bundle branch enters the right side of the interventricular septum, and that becomes a subcordia on the right side of the septum. A large part of it continues in the septum marginal trabeculum as moderated band, and it reaches the anterior wall of the ventricle. Purkinje fiber then spread out then at the endocardium. Left bundle branch descends down the left side of the ventricular septum and divides in the Purkinje fibers that are distributed to the septum and the left ventricle. Purkinje fibers, it is a subendocardial connection cells. It is a specialized cell. It is seen in the subendocardial surface of ventricular walls. It is abundant with glycogen and extensive gap junctions are present, and it transmits cardiac action from the myocardium of the ventricle. It causes coordinated ventricular contraction and moves the blood from right ventricle to the pulmonary artery and ventricle to the aorta. These are the inherent rate at which the conduction system will beat at 60 to 100 beats per minute, and AV node it beats at 40 to 60 beats per minute. Bundle of His, it will beats at 40 to 60 beats per minute, and left and right bundle branches 20 to 40 beats per minute, and Purkinje fibers it is 20 to 40 beats per minute. Moving on to the arterial supply of conduction system, the whole conduction system is supplied by right coronary artery, except a part of left branch which is supplied by left coronary artery. Sinoatrial node receives its blood supply right artery 60%, and 40% is from LCX, and atrioventricular node receives 90% of its supply from the right coronary artery and 10% from the left circumflex artery. And bundle of His will receive blood supply mainly from the right coronary artery and also from the septal branches of left anterior descending artery. Right bundle branch receives blood supply from the septal branches of left anterior descending, and left bundle branch is supplied by left anterior descending. Moving on to the ECG components and the conduction system. From the SA node initiates the atrial contraction, so it proceeds before the P wave in ECG, and the impulses arriving in the AV node will be denoted by P wave, and impulse passing across the bundle of His is denoted by the PR interval, and below that bundle of His conduction system is represented by the PR segment. P wave represents the depolarization of the atria in response to SA nodal triggering, and PR interval is AV nodal delay that will allow the atria ventricles to fill, and QRS complex is for depolarization of the ventricle, and ventricular depolarization is represented by T wave. A small review over the heart blocks. There are types of heart blocks. First degree heart block, it is there is only a prolonged PR interval will be there, and nothing will be there. All other will be normal. And a second degree heart block, we will have two types. One is MOBIT 1 and MOBIT 2. MOBIT 1 is there will be a long progressive prolonging of PR interval, and suddenly one QRS complex will be missed. And in MOBIT type 2, PR interval, there will be a sudden interruption in QRS complex. Third degree heart block, there will be complete dissociation between the atria and ventricle. Conduction system defects, it leads to cardiac arrhythmias. The most common cause for conduction system defect is atherosclerosis. If the AV bundle fails, there will be alteration in the rhythmic contraction of the ventricle and leading to ventricular arrhythmia. In complete heart block, complete bundle branch block, there will be complete dissociation of the atria and the ventricles. One more topic is there, bundle of Hent. will be seen in a patient with pre-excitation syndrome. It is an alternative pathway. It bypasses the AV node, and it will be the direct connection between the atria and the ventricle. It will result in the earlier activation of the ventricle, then it passes to the AV node, and it will result in paroxysmal atrial tachycardia. Thank you.
Thank you, Dr. Nivedita. Very brief outline about the conduction system, though it was disturbed by network, but you have made it very well. Thank you very much.
Thank you, sir.
She was briefing about the conduction system, about the where it starts, where it ends, all those things. You are very well aware about all those things. SA node, AV node, and then bundle of his, and then left bundle, right bundle, and then Purkinje bypass. These things and the conduction delay, all those things, everyone aware about it. The most important thing you should know about it is the blood supply to the conduction system. 90% of the conduction system is supplied by the right coronary artery, and left bundle and some of the left anterior fascicle is supplied by the left anterior descending artery. So this is the in cross about the blood supply, because when you go about the involvement of any coronary arteries, that have its own effect on the conduction system that can produce different types of arrhythmias. So whenever there is an RCA involvement, there will be a cross arrhythmias, particularly blocks. Whenever there is involvement of left anterior descending artery, there will be a septal branch related arrhythmias. So in cross, right coronary is a major part to the conduction system, and left coronary supplies left anterior fascicle and left bundle branch. And there are many accessory pathways. That is too much into theory. I don't want to go into that, but you should remember a lot of accessory pathways are there that can produce so many syndromes. But we are not bothered about those syndromes. We'll go straight to the applications of this conduction system with the pacemaker and the anesthesia. So for that, I invite our next speaker, Dr. Chandakala. She's going to talk about pacemaker and its functioning. Dr. Chandakala, please.
Good evening, everyone. Am I audible, sir?
Yeah, please, madam.
Yes,
please share your slides.
Yes, madam, please turn on your video.
So am I audible?
Yeah, it is audible and visible. Please go ahead.
Good evening, everyone. I thank my... Hello?
Yeah, please.
I thank mainly the ISC Pudukkottai members for giving the opportunity to our college. I thank my beloved ma'am to give an opportunity for me. Kindly bear with me for another 30 minutes. It's artificial pacemaker we are going to discuss. My content of the study is we're going to see about definition, history and anatomy, physiology. What are the terminologies used, function, indication, what are the types, how we are going to implant, certain nomenclature, complication, recent advances, and additional commands, and the patient education. Pacemaker is nothing but the electronic device that provides the repetitive electric stimuli to the heart muscle when the patient intrinsic pacemaker fails to provide the perfusing rhythm. To repeat our inventors, we just going to discuss about the history. The concept of the artificial pacemaker was started in the year of 1932, and the first transcutaneous pacemaker was introduced by 1950. Whereas in 1958 and 59, subsequent first implanted transvenous pacemaker and first successful long-term implantable pacemaker was identified. As I said about the introduction, this is Arne Larsen who received the 26 devices during his lifetime. and who is the first to receive the implantable pacemaker. Coming to the parts of pacemaker, it consists of the power source, power generator, electrodes, timing control, sensing amplifier, and output driver. Design, the pacemaker generator is nothing but a hermetically sealed device having the circuitry and the battery that determine the rate and strength of the electrical stimulus delivered to the heart. Power source is the lithium battery, whereas the sensing amplifier processes the electrical manifestation of naturally occurring heartbeats as sensed by the electrodes. Leads we are using is the insulator wire that delivers the electrical impulse from the generator to the heart and senses the cardiac depolarization by the electrodes at the end, which touches the heart valve. The computer logic for the pacemaker and the output circuitry, which delivers the pacing impulse to the electrodes. The outer case is a titanium, which is inert in the body. It can be rarely rejected by our immunity. This is a pulse generator. The terminal end is the electrodes and connective part is the leads placed below the clavicle. Anatomy of the pacemaker consists of three parts mainly. Connector, which includes the atrial connector and the ventral connector. Hybrid includes about 5 systems, resistors, output capacitor, clock, reed switch, telemetry antenna, which stores the information, and the battery, which is the lithium. This is a circuit of the pulse maker, power source, sensing amplifier, timing control, output driver, electrodes, which relays back the information back to the pulse generator, vice versa. Once the impulse is started, it begins in the pulse generator, flows through the lead and the cathode, negative terminal. It stimulates the heart and returns back to the stimulus where it originates by the anode, positive terminal. A unipolar pacing system contains a lead with only one electrode within the heart. In this system, the impulse flows through the tip of the electrode, which is the cathode, stimulates the heart, returns through the body fluid and tissue to the internal pulse generator, which is the anode. A bipolar system contains the lead with 2 electrodes within the heart, where the impulse flows through the tip electrode located at the end of the lead wire, stimulates the heart, and returns to the ring electrode above the lead tip. We have to look after the certain pacemaker terminologies, which include a stimulation threshold, is nothing but the minimal electrical stimulus needed to consistently capture the heart outside of the heart's refractive period, the point at which the depolarization occurs to the myocardial response to the pacing stimuli. Once the capture occurs, the refractive period is reduced. This is a non-capture where the refractive period is above. The desired level is 0.5 to 1 milliampere. Strength derivation curve illustrates the relationship of amplitude and the pulse width. The values above or on the curve where the capture occurs. Capture is nothing but the depolarization of atria or the ventricles in response to the passing stimulus. Whereas sensing is the ability of device to detect the intrinsic cardiac activity. It should not be undersensed where there are failures to sense. It should not miss the either P wave or the R wave. Oversensing is the too sensitive to activity, which is mistaken extracardiac activity as its intrinsic and it can be oversensed. Amplitude is the amount of voltage delivered to the heart by the pacemaker. It reflects the strength or the height of the impulse. It must be large enough to capture and sufficient enough to provide the appropriate pacing safety margin. Pulse is the time of the pacing pulse, which usually length of the time each pulsing pace is delivered and must be long enough for depolarization to disperse to the surrounding tissue. It is usually expressed in milliseconds. Whereas impedance is the opposition to the current flow. It measured in ohms. High impedance reduces the battery drain and increases the longevity, whereas low impedance increases the battery drain and decreases its longevity. Factors influencing impedance are resistant to the countercoils, tissue between the anode and the cathode, the electrode and the myocardial interface, size and shape of the electrode tip and its surface area. Lead maturation process is a fibrotic capsule develops around the electrode following the lead implantation. Trauma to the cells surrounding the electrode producing edema and later on to the fibrotic capsule. This inexcitable capsule decreases the current at the electrode interface and there is need of increased energy. It occurs in 3 phases, whereas in acute phase, the initial low threshold will be maintained. In the peaking phase, the initial rise to the highest, followed by the decrease of the threshold over 6 to 8 weeks once the edema or inflammation subsides. Whereas in chronic phase, it's a higher threshold but lesser than the peaking phase. There is a steroid-eluting leads which reduces the inflammatory process, thus exhibit little to or no acute stimulation threshold peaking either in low or chronic thresholds. This is a picture showing the silicone rubber plug containing the steroid, a porous platinous tip for the steroid elution, and tines for the stable fixation. Lead maturation process, fibrotic capsule developing around the electrode leading the implantation, followed by the black non-excitable fibrotic tissue in chronic phase. Pacemaker timing, a pacing cycle is a time between the two consecutive events in the ventricles or the atria. The timing interval is any portion of the pacing cycle that is significantly affecting to the pacemaker operation. Example, AV interval or the refractive period. General guidelines, the pacing threshold of a newly implanted lead should not exceed the 3.75 volts at 0.5 milliseconds. The impedance should be 250 to 1300 ohms. For the right ventricular lead, the intrinsic wave should be at the 5 to 6 millivolts in amplitude. And for the atrial lead, the intrinsic P wave should be at least 1 millivolts in amplitude. First 2 weeks, there will be sharp rise in pacing threshold since because of the tissue reaction despite steroid at that time. Pacemaker usually performs the function of stimulating the cardiac depolarization, senses the intrinsic cardiac function, respond to the increased metabolic demand by providing a rate responsive pacing, provide diagnostic information stored by the pacemaker. The common clinical identification mainly used for the pacemaker is either failure to impulse formation or failure of conduction. Most common clinical condition we use is the sick sinus syndrome and the complete heart block. It's indicated in sinus node dysfunction with symptomatic bradycardia and chronotropic incompetence, where the individuals fail to achieve 80 to 85% of maximum heart rate predicted at the peak exercise, either with a heart rate less than 40, recurrent syncope, slow junctional rhythm, first and second degree heart block with a symptom similar to pacemaker syndrome on the hemodynamic compromise, a second advanced second degree or third degree block with asystole more than 3 seconds of duration, symptomatic bradycardia, escape heart rate of less than 40, any post-cardiac ablation or cardiac surgery, chronic bifascicular block, high-risk patient with congenital long QT syndrome, NIHA class 3 or class 4 heart failure symptoms, overdriving supraventricular tachycardias and ventricular tachycardias. Based on the pacing, we divide the pacemakers into percussive, transcutaneous, epicardial, transvenous, either temporary or permanent, duration, temporary and permanent pacemaker. This is picture showing that single chamber, dual chamber, and permanent single chamber pacemaker. Pacing mode functions includes various types. Asynchronous pacing, where there is no sensing circuit, only the output circuit. Paces at the programmable preset rate, independent of inherent heart rate. Its advantage is mainly simple, but disadvantages competition, sustained tachycardia, fibrillation, pacemaker syndrome, or the potential complication when pacing occurs in presence of the intrinsic myocardial activity. You see the example A00, B00, we see on later. Single chamber demand pacing, it paces only at the preset rate only. Atrial pacing, it increases the cardiac output by 26%, whereas the atrial contribution contraction contributes to the cardiac output by 15 to 25% of diastolic filling in the left ventricle. It decreases the coronary resistance, thereby increasing the coronary blood flow. It also reduces the incidence of atrial fibrillation. It's seldom used in USA only. It's indicated mainly in the sinus bradycardia, slow junctional rhythm, suppression of ventricular and atrial complexes, for overdriving pacing in case of atrial flutter and fibrillation. Rapid atrial pacing accomplished with a rate of 800 beats per minute or 10 beats faster than the flutter rate with a full current of 20 milliampere, usually for 1 minute. Increase the rate till the morphology changes and the patient should be turned off abruptly. It convert the sinus rhythm, then followed by a pulse and followed by a sinus rhythm. It acts mainly by the interrupting the re-entrant circuit. This is a single chamber in right ventricle. Coming to the ventricular pacing, the ventricular output is usually set at 10 to 20 milliamperes synchronous demand mode. The rate selected depends on whether the pacemaker is being used for bradycardia backup or pacing at the therapeutic rate or for the overdriving pacing. Indicated in case of slow ventricular response to the atrial fibrillation or the flutter or failure of atrial pacing or the ventricular tachycardia. The mainly disadvantage is dysynchronous left ventricular electrical activation, and the mechanical contraction. Whereas in right ventricle is usually contracted first, followed by the passive delayed contraction of the left ventricular via, which worsens the congestive cardiac failure and diminishes the left ventricular ejection fraction. This is asynchronous pacing. In presence of intrinsic activity, the pacing is inhibited. In presence of normal sensing, the ventricular pacing is occurs. Coming to dual chamber pacing, it's atrioventricular pacing. Because of the success of transvenous leads, bioengineering advances such as a thinner polyurethane insulation and improved device programmability, indication for the atrioventricular pacing is broadened. The programmable features includes mode of pacing, AV delay, the maximum atrial rate that the ventricle will follow, which is called as atrial tracking, atrial pacing commencement at the minimum sense rate where the atrium is started to pace. Initially, the atrium is stimulated to contract first, then after an adjustable PR interval, the ventricle is stimulated to contract if there is no intrinsic ventricular activity sensed by the ventricular pacing lead. The main advantage is it increases the cardiac output under the extreme stress and decreases the atrial fibrillation. Disadvantage mainly is a pacemaker mediated tachycardia, ventricular dysrhythmia, decreased LV ejection fraction in case of pre-existing LV dysfunction. One lead is implanted in the atrium and another lead is implanted in the ventricle. The same RV is almost present in all devices at this lead, RV lead. Coronary sinus lead we used in case of biventricular device, and RA lead, dual chamber devices have also these leads. The picture showing the biventricular, dual chamber, and the atrium. This is a 4-phase of dual chamber pacing. In case of atrial pace and the ventricular pace is first usually rate at the 60 beats per minute, whereas in case of second one, it's only the atrial pace, but only the ventricular sense, AP and VS. Biventricular phase, normally the left ventricular septum and free valve contract simultaneously. In patients with most common intraventricular conduction delay seen in patients with a congestive cardiac failure is LVV. On the mechanistic level, individuals with LVV demonstrate a ventricular dyspnea, a phenomenon whereby the left ventricle conducts in the stepwise process. The left ventricular septum and the left ventricular lateral wall contract simultaneously in normal individual, which is altered in the LVV presence, which leading to the impairment in LV systolic function, increased myocardial work, and the oxygen consumption. Hence, we need to resynchronize the heart by pacing both the ventricular septum and the left ventricular field simultaneously by keeping the pacemaker lead in the right ventricle for the left ventricular septum and pacemaker lead in the coronary sinus for the free valve. It's usually indicated in the sinus rhythm, which is ejection fraction less than 35%, either with or without LVV, with a long QRS duration of more than 120 seconds, with the NIGA class 2 or class 4 symptoms, and patient requiring more than 40% of ventricular pacing alone. Coming to the next mode, it's a rate responsive pacing. When the need for the oxygenated blood increases, the pacemaker ensures that the heart rate increases to provide the additional cardiac output, which is slowing, sleeping, wake up, once walking, running, and again for the resting. It's a programmable pacemaker, rate responsive or adaptive. Various activity detecting sensors are included, providing the muscle movement, respiratory rate, minute ventilation, central venous temperature, QT interval, myocardial contractility, oxygen saturation, and pH in the mixed blood. Ventricular depollution gradient, currently used in US, rely on the changes in minute ventilation even through the intrathoracic impedance. Moving to the procedure with implantation, we can either done in the local anesthesia or under mild IV sedation. The pacemaker lead is usually enters the external jugular vein, and the lead is tunneled subcutaneously between the pacemaker and the external jugular vein. Pacemaker generator is placed beneath the skin in the pectoral region, usually on the non-dominant side of the patient. The tip of the lead is placed as we need in the apex of the right ventricle, atrium, or duval, depending on the mode. So picture showing the internal and the external implantation. Coming to the nomenclature, in 1970, the Inter-Society Commission of Heart Disease Resources established the 3-letter classification code. Later in 1980, it becomes a 5-letter code where the last 2 digits can be deleter if not applicable. In 1987, it becomes the NBG pacemaker core after being adopted by both North American Society of Pacing and Electrophysiology, which is called as the Heart Rhythm Society, and British Pacing and Electrophysiology Group and generic code. First one is a chamber paced. It can be none, atrium, ventricle, or dual. Chamber sensed, none, atrium, ventricle, or dual. Response to the sensing, it's none, triggered, or inhibited, or either dual activity. Programmability and rate modulation, it's none, simple programmable, multi-programmable, and communicating or rate modulation. And fifth one is the anti-tachycardia function, either none, pacing, or short, or dual. Just as a slide example, D is for dual chamber, paced, dual chamber sense. Response to sensing is both dual trigger and inhibitor. R is the rate modulation. This is for the anti-bradycardia pacing. Chamber 1 is already known. Atrium, ventricle, or dual. It's either single. Chamber change is the same. None, atrium, ventricle, or dual. S is for single. Response to pacing either triggered or inhibited. Rate modulation under multi-site pacing either atrium, ventricle, or dual. Coming to the temporary pacing, so temporary pacemakers can be used temporarily, either supportively or prophylactically or life-savingly until the primary condition responsible for the rate or conduction disturbance resolves. It's mainly indicated in case of maintenance of adequate heart rate and rhythm in special circumstances such as surgery, post-operative recovery, cardiac catheterization, or the angioplasty. Before the permanent implantation, as prophylaxis after the open heart surgery, acute anterior MI with second degree and third degree AV block, acute inferior MI with symptomatic bradycardia and the AV block. This is the methods: percussive, transcutaneous, epicardial, transvenous. Percussive method is also known as transthoracic mechanical pacing. It's use of a closed fit on the lower edge of the sternum over the right ventricle in the vena cava, striking from the distance of 20 to 30 centimeter to induce a ventricular beat. This must be done to raise the ventricular pressure to 10 to 15 mmHg. It's an old procedure used only in the life-saving. Transcutaneous pacing is an external pacing composed of two adhesive conducting pads that are placed externally on the chest wall. One pad is placed anterior to the left of sternum, and the posterior pad is placed directly behind the anterior pad and to the left of thoracic spine in the anterior posterior position or in the anterolateral position respectively. The electrodes are incorporated into the pads and covers over the large area of the skin. The pads are connected to the external pulse generator. This temporary measure is used in the event of bradyarrhythmias with poor perfusion and low blood pressure until the transvenous pacing is inserted. It's a more energy required used to pace the heart since it is used externally. Pulse width should be 20 to 40 and high output 20 to 100 to 200 milliseconds. Transcutaneous pacing. First one is the anterior and the chain behind the posterior. Second one is the anterolateral. Transthoracic or epicardial pacing accomplished through the electrodes that are loosely attached to the surface of the heart during the cardiac surgery. Two surgical wires normally attached to the atrium, which is right of the sternum, or the ventricle to the left of the sternum or the both. Atrial wires is inserted into atrial terminal and ventricle wires are inserted into the ventricle terminal on the pulse generator. It's indicated in aortic valve replacement, AV canal defect, repair, tricuspid surgery, or Epstein alembic correction. It's used beneficial in many patients to optimize the hemodynamics at the conclusion of bypass and for several hours in ICU. This is a cardiac patient, atrial electrodes, ventricular electrodes, both are negative and positive terminals. Transvenous pacing, its insertion sites we used is internal jugular vein, subclavian vein, femoral vein, brachial vein, and external jugular vein. Threading an electrode catheter through the venous sheath under the fluoroscopic guidance into the right atrium or the right ventricle. If we are using the permanent pacemaker is planned, avoid the ipsilateral vein. If the patient has undergone thrombolysis recently, avoid the femoral and IJV approach is needed. Leads we used for the transvenous pacing include the passive fixation, which is the tined ends lodged in the trabeculae or the pectinate fibrous mesophoque of the heart tissue. Whereas in active fixation, it's a screw-in type extends into the endocardial tissue. This is a lead used in the transvenous catheter. Transesophageal or a gastric pacing, it's the flexible electrode on the tip of the catheter passed down to the esophagus for atrial pacing and advanced to the stomach for the ventricular pacing. It's rarely used now. Coming to the implantable cardioverter defibrillator, It provides anti-tachycardia, anti-bradycardia phasing, synchronous with cardioversion or non-synchronous defibrillated shock, telemetry, and diagnostics, including the stored event electrograms and history logs. Pacing functions have all incorporated with the pacer, cardioverter, defibrillator also. ICD use the transvenous lead systems for pacing and shock, whereas epicardial leads is used in case of infants and small children. It consists of the battery with high power density which is used to power the pulse generator, the circuitry, and the aluminum electrolytic storage capacitors. It can charge up to the 41 joules. Ventricular demand phasing for the bradycardia is a standard feature for the all ICD. Now the modern pacemaker comes with a rate adaptive phasing and automatic mode switching. They usually measure the cardiac RR interval and categorize the rate depending on which the internal computer will decide and delivers the response based on its programmed algorithm. If shock is chosen, the internal capacitor is charged, takes 5 to 13 seconds depending on the energy amount to deliver and age of the device. Programmed to such a way that it reconfirms the VT or VF after charging to avoid the inappropriate shock. It delivers no more than 6 shocks per episode. It also redetects the successful termination of the arrhythmia once the sinus rhythm is involved. It is indicated mainly in hemodynamically significant ventricular tachycardia or VF or recurrent fibrillation, ischemic or non-ischemic cardiomyopathy with a EF less than 35, but without the recent episodes of MI within the 40 days or revascularization within 3 months, and either with NIGA symptoms of class 2 or grade 3, inherited channelopathies and cardiomyopathies. A central vein should be avoided with the recently placed less than 1 month, which leads to the dislodgement. The subcutaneous ICD is implanted along the left mid-axillary line. The lead is tunneled across the left lower chest to the xiphoid process. The lead is then directed superiorly along the left sternal border so that the lead defibrillator coil is along the side of sternum. Here the can act as a cathode and the defibrillator will act as an anode. So X-ray feature showing the ICD. So fibrillate generic code for the ICD. Either one is shock chamber, atrium, ventricle, dual, anti-tachycardia phasing chamber, atrium, ventricle or dual, tachycardia detection either by electrocardiogram or the hemodynamic, anti-bradycardia phasing, none, atrium, ventricle and dual. This is a short form. ICDS, it includes shock capability only. ICDB is with the bradycardia phasing. ICDT with the anti-tachycardia phasing. Other temporary phasing modalities include the current monitor and defibrillators can provide a transcutaneous phasing through the gel plates attached to the chest and the back. Placement of 4 to 5 French temporary transvenous intraventricular phasing wire is indicated if the patient is pacemaker dependent, which needs a high threshold or failed epicardial wires. It can be placed through the IJV or the subclavian veins, which have the balloon tips that assist in the floating the phasing the wire into the right ventricular apex. Occasionally, fluoroscopy may be required. Paceport catheter with this extra channel of the Swan gun catheters that open into the right atrium and the ventricle, through which the pacing catheter can be placed. It usually done during following the minimal invasive cardiac operations. Coming to the complication, the failure to the function, change in threshold, oversensing problems, competition with their own rhythm, inadvertent triggering of ventricular tachycardia or ventricular fibrillation, pacemaker's syndrome, which is nothing but the hemodynamic instability by the ventricular pacing and loss of AV synchrony, mediastinal bleeding, pneumothorax, hemothorax, inability to remove the wire electrodes, which is temporarily fixed from the heart, local infection. Triplet syndrome is nothing but when the patient manipulates the generator, it leads to the fracture or dislodgement of the lead. And finally, the cardiac perforation, which is the Coming to the additional points, there is an elective replacement indicator, a signal indicating battery depletion. Even though it indicates it takes several months for the complete depletion, by meantime, we can replace the battery either under local anesthesia. To summarize, AV pacing is preferable to the ventricular pacing since the atrial contribution to the ventricular filling. AV delay is usually prolonged after the bypass surgery, shortening of it, which improves the hemodynamics. Atrial pacing alone in patients with normal conduction is superior to the AV pacing. Biventricular pacing provides superior hemodynamics to RA or RV pacing in patients with an impaired left ventricular function, wide QRS and AV block. Lifespan of single chamber pacing is 7 to 12 hours. Dual chamber is 6 to 8 hours. Since the ICD depends both on battery and the capacitor, it takes 5 to 8 years. Recent advances, now there is a MRI compatible pacemaker, REO-MRI shows can also prevents the damages from the radio waves and the magnet. Operate in rate responsive modes, dynamic AV delay feature automatically adjusts to mimic the physiological response. Leadless pacemaker is an anastatic 10 times smaller than the conventional pacemaker, can be repositioned easily by steerable catheter through the femoral vein. Steroid eluting leads. Dynamic pacemaker, which is the artificial heart rate, compensates for both the actual respiratory loading and the anticipated respiratory loading in spite of being static. Microprocessor controlled pacemaker. Finally, the patient education is must, which should avoid the magnet, earpiece of phone, jewelry, wrap should not be wear near the generator for more than few seconds. Phone should be 6 to 12 inch away. Avoid arm raise and weight lifting for initial few weeks after the implantation. This is just the example. DDD is nothing but both the atrium and ventricular paced, atrium and ventricular sensed, and response is dual, either inhibited and triggered. This is fully automatic or universal pacemaker, whereas VVI is a ventricular pacing, ventricular sensing, and inhibited response to the sensed QRS. This is asynchronous mode, A00, V00, D00, synchronous mode, AAI, which is atrial pacing, atrial sensing, inhibited response to the sensed PV. Whereas VVI is a ventricular pacing, ventricular sensing, inhibited response to sensed QRS. Complex. Thank you for the patient listening.
Thank you very much, Dr. Chandrakala. It was a very elaborative lecture on artificial pacemaker and its functioning, covering that about the pacemaker components, pacemaker terminologies, and the pacemaker nomenclature by using that Heart Rhythm Society. Previously, it was called as North American Society of Electrophysiology, Pacing and Electrophysiology, and also British Pacing and Electrophysiology. Now they're together, they're calling as Heart Rhythm Society. So with that, there is a nomenclature for pacemaker components, as well as the nomenclature for the ICD is also different. And you are clearly told about that single chamber, dual chamber, and ICDs, all those things. And recent advances about leadless pacemaker. That is the way to go. No doubt about it. People are started using. I think we can have the questions at the end. Thank you very much for the excellent lecture, and we'll move on to the next lecture by Professor Dr. Narmata about the most important topic, pacemaker and anesthetic implications.
Yeah.
Madam, please.
Yes, sir. Good evening, sir. Good evening, everyone. First of all, I ask a big sorry from my side for being the delay from my team. And I would like to thank my teacher and mentor, Dr. Elam, sir, and ISA Pudukkottai President, Dr. Petyasamy, Dr. Suresh Kumar, for giving this platform. It is a wonderful platform for upcoming anesthesiologists like us. And I would also like to thank Dr. Kumar, sir, for sharing this session. And please enlighten us with your knowledge as a cardiac anesthesiologist, sir. So, Shilpa, please, can you share my slides? Hello.
Yeah, it is visible, madam. Can go to the slideshow.
A very good evening to one and all. First of all, I would like to express my gratitude to my teachers, Dr. A.L.M. sir, and ISA Pudukkottai GE members for giving me this wonderful platform. Today's my topic is on anesthetic implications in a patient with pacemaker. So actually, recently it was termed as cardiac implantable electronic devices. So this includes a pacemaker, an ICD, and a CRT device. So all about the details of the pacemaker was explained in detail by my previous speaker. So directly let's get on to the topic. So when you come to the pacemaker, patients with the pacemaker, implanted pacemaker, so during my PG period, actually it was a remote topic. We will usually try to skip it. But nowadays, because of the exponential increase in the cases, So they should have a basic knowledge how to anesthetize a patient coming with the implanted pacemaker. So here we are going to discuss these topics under the headings. So what is the preoperative assessment? So intra-op management and the postoperative considerations and the special situations. So in preoperative assessment, first you have to establish whether the patient has a pacemaker. So this is mainly by means of a focused interview about the pacemaker to the patient. So you should get a detailed history about what is the time of implantation, what was the indication for the pacemaker. Some patients may be intelligent enough to give you all the details. If not, you can verify their medical records, or they may be carrying a pacemaker card. So that has the details of about the pacemaker. Next thing is, you have to ask for symptoms, any new onset of symptoms after the implantation of pacemaker, like dyspnea, orthopnea, or any giddiness or syncopal attacks. So that indicates there is a pacemaker malfunction or a pacemaker syndrome. Next is, you have to do a detailed physical evaluation on examination. So apart from the routine physical examination, you have to examine the pacemaker implanted sites. So commonly it is implanted in the intraclavicular area, right or left intraclavicular area. And so this, you can see there is redness and some sinus formation. These all indicate there may be a lead malfunction or a pacemaker malfunction. So examine the pacemaker implanted area very carefully. This is a subcutaneous ICD that is implanted in the left lateral wall. So you have to for the this also, whether it is implanted, anything is implanted in the left lateral wall, or sometimes very rarely in a pediatric case, it can be implanted in the abdominal wall. So these are the sites you have to do a thorough examination. So after that, if you have a CIED team that is consist of an electrophysiologist, so who consists of an electrophysiologist, cardiologist, and a physician nurse, they will be able to provide all the details of the pacemaker, like what is the mode, what is the type of device, everything. So otherwise, then you have to do the evaluation of the pacemaker. So this you can simply do by some of the common investigations you do daily in and out. So what are the things you have to evaluate? So what is the type? What is the manufacturer? What is the time of implantation? What is the date of lost introgation, battery life, and effects of magnetic application? Coming to the time of implantation, why this time of implantation is important? So in a case of recently implanted pacemaker, initially for the first 2 weeks, there is increase in the pacing threshold up to 10 times because of the tissue reaction around the electrode tip. Next, secondly, there will be air entrapment inside the packet. So whenever you are taking up this patient under general anesthesia, the nitrous oxide can cause expansion of the air packet and can cause lead dislodgement. Whereas in a chronic case, it is well, because the fibrous tissue is well formed and it is fixed to the endocardium. So this there is this possibility of lead displacement is very minimal, and the pacemaker threshold also is decreases. That is why the time of implantation is more important. Next, by a means of a simple investigation, that is just an X-ray, you can come to a conclusion about, can get answer to most of the questions you need. So I have some of the examples of the X-ray. For example, if you have an X-ray like this, okay, just a minute. So this is a pulse generator, and this is the lead. So that this is coming and ending in the right ventricle. So from this, so this is a single chamber ventricular pacemaker. So the indication should be an AV block or a complete heart block. And here you can see, you can even see SGM, that is the company or manufacturer's name. So you can see the manufacturer's name, and from that there will be a toll-free number for each company. By calling that, you will also get the details of the device. Okay. Next, if you have a patient with an X-ray like this, then what is this? So you can see there are, this is the pulse generator. Here the leads are coming. They are highly opaque, radio opaque lines are seen here and here. So this is a high voltage coils, that is shock delivering coils. So this is nothing but a ICD. So the patient should be suffering from ventricular arrhythmias or a VT. So that is the indication. And if you see in this X-ray, so here there are 3 leads you can see. One is the atrial, that is the right atrial lead, and biventricular, one in the right ventricle and another in the coronary vein. So the patient has a cardiac resynchronization therapy device. So he is suffering from a cardiac failure. Usually it is implanted for patients with an ejection fraction of less than 35%, just to maintain the synchrony between the 2 ventricles so that it increases the cardiac output and the stroke volume. For example, if you're coming an X-ray like this, so in this you can see this pulse generator is surrounded by multiple coilings of the lead. So actually, initially within a month of implantation or within 6 months, there are certain syndromes. So the leads can get coiled around, so the lead gets retracted. So and it can cause stimulation of the phrenic nerve, diaphragmatic stimulation. So the patient will have symptoms like hiccups, recurrent hiccups, or if there is any stimulation of the brachial plexus, the patient can have impulses in the arm. So this is a Twiddler's syndrome. So this is called a Twiddler's syndrome. So you have to ask the symptoms also, or you should be very careful if the patient tells these symptoms. Okay, what is this? So this you can see this is a pulse generator with a lead ending in the right atrium. Here it is outside the cardiac shadow. That means the lead has migrated outside the heart. So it can be a lead migration. So think of lead malfunction in this patient, and better do a full device interrogation before taking up for a surgery. Okay, if you're seeing an X-ray like this, so what is this? There are no leads are there, but you can see a capsule-like thing in the right ventricle. So this is a leadless pacemaker. So this is the latest technology in the evolution. So this is a leadless pacemaker, but it's too costly. It cost around 8 to 10 lakhs. And okay, if you are seeing, this is a very rare picture. So this is a patient with a CA breast. So the patient had initially the pulse generator was implanted on the left side. Because the patient had a CA breast and undergone MRM, it was relocated to the right side. So for this, they have attached this lead extenders. So these are nothing but lead extenders because they have changed the position. Otherwise, it is a CRT device. So you should not get confused if you see extra lead extenders like this. Okay, now let us see some of the, this is an interesting X-ray. Here you can see the pulse generator is in the abdomen, that is near the lumbar spine. Now, you can think it can be a pacemaker implanted in the abdominal wall, but you have to see whether the leads where it is ending. You can see it is not ending in the heart. It is somewhere near the, it is in the middle of the spine. So this is actually a gastric pacemaker implanted for a weight management. So you should also think in mind, just seeing a pacemaker, it doesn't mean it is a cardiac pacemaker. Okay, so from an X-ray, you can have these many details about the type, manufacturer, any lead fractures, then lead displacements, and what was the indication, everything you will be able to know. So this is a toll-free number I told. So you can call this. If you know the device, you can call this and also get the details of the device. Next, coming to the battery life. So battery life, according to the Heart Rhythm Society, there should be a minimum of 3 months of battery life before taking up a patient for an elective surgery. So why this is important? Because the battery life of and this is not the same for all devices. The lithium battery may come for 5 to 8 years, but depending upon the type of device, what is the pacing rate, how many shocks it is delivering per day, so this battery life will start to reduce. So whenever you are taking up a patient for surgery, the pacing in the perioperative period is not the same as that in the normal time. Why? Because he will be exposed to the drugs like opioids, beta blockers, or volatiles that can all act on the SE node, and they can alter the pacing rate. They can increase the pacing rate, and also any untoward complications in the postoperative period can increase the pacing requirement. So that is why minimum of 3 months of battery life should be there. And another important thing is, while we are changing this pacemaker to the asynchronous mode, the pacing rate, whatever the set rate, is not the same as the delivered rate when the battery life is very less. For example, it varies with the manufacturers. For example, if it is a Medtronic, if the initial set rate is 85, if the battery life is very less, then it will reduce in a binary fashion. That is, from 85, it will reduce to 65. If it is a St. Jude company, for example, if the basic rate is usually their basic rate is 100, it will reduce in a stepwise pattern. So that is why minimum of 3 months battery life should be there. Otherwise, you have to change the battery before taking up the patient for an elective surgery. Next is a device interrogation. So this is usually done when the patient goes home. This is done by the manufacturer, that is company's experienced programmer will come home and then do this device interrogation. You should ask the patient whether it was checked after the implantation and it was done. There is a protocol when it should be done. It should be done within 12 months if it is a pacemaker, or within 6 months if it is an ICD, or 3 to 6 months if it is an CRT. If it is not interrogated within this period, then you should ask the programmer to do a device interrogation before the elective surgery. Okay. Now, how we can know about the pacemaker function? So we have know about the type, everything. So pacemaker modes and functions, so that we can easily come to a conclusion from the 12-lead ECG. So this is a figure explaining the different types of pacemaker, atrial, ventricular, and a dual mode pacemaker. So first you should know how a basic paced ECG will be. So whenever you see the ECG in a paced ECG, so this is the pacemaker stimulus, which is followed by the P wave. So this is a atrial chamber pacemaker. So usually the P wave morphology will be upright and it will be resembling the normal P wave, or sometimes it may be miniaturized if the lead is somewhere higher up in the right atrial appendage. Then the QRS complex will be in the same direction as the P wave. In the case of a ventricular pacemaker, the artifact, that is the pacer stimulus, is seen before the QRS complex, and this QRS complex depending upon the position of the lead. If it is the right ventricle lead, you will have a broad and bizarre QRS complex resembling an LVB pattern. Why? Because the cardiac impulse has to travel from the right, that is it's the opposite direction, from the apex to the base, from the right ventricle to the left ventricle. So it will have a wide and bizarre QRS complex resembling an LVB. If the lead is in the left ventricle, it will resemble an RVB. So you have to see in the paced ECG whether the spike is before the P wave or QRS, or if it is present both, that means it is a dual mode. So, and also the QRS morphology. Another thing is, in a paced ECG, the QRS will be in discordance with the T waves. If here you can see it is in the negative direction, QRS, and the T wave is in the opposite direction. So definitely always there will be a discordance between the QRS and the T wave in a paced ECG. So that is how you can read the paced ECG. Okay. Coming to the ECG interpretation, there are certain steps you have to see. Just with a quick look, you can diagnose the pacemaker, what is the pacing mode, whether it is functioning, whether there is any malfunction, everything you can diagnose. So first you have to see what is the rate, whether there is any irregularity. So that means if there is an irregular pulse, the pacemaker and the patient's intrinsic rhythm are competing with each other. Next is you have to see whether there is a P wave or QRS complex following every pacer spike. Third, look for any pauses or asystole throughout the lead. Fourth is, are there any spikes during or following a normal ventricular contraction? So now let us see some examples. So this is, here you can see this is the pacemaker stimulus before the P wave. Sorry. So this is the pacemaker stimulus before the P wave. So this is a atrial pacemaker. This is followed by a normal QRS complex. Here is also the stimulus is seen P wave QRS. Here you can see this is the patient's intrinsic P wave. So here the pacemaker doesn't stimulate. So that means it is inhibited here. So this is a AAI mode. That means atrium is, first is the chamber paced, chamber sensed, and the response. So atrium is paced, so it senses this P wave, so it inhibits. So this is an AAI mode. Okay, for example, If you can see this, so this is a ventricle, pacemaker, because the stimulus is seen before the QRS, and as you see, it is a wide and bizarre QRS complex. And here you can see the spontaneous QRS complex. So after seeing this, it doesn't deliver the stimulus here. So it is a ventricle is a chamber paced and chamber sensed, and I is the inhibitory response. Okay. So this is a dual mode. This has 4 types of ECG pattern. Actually, this was discussed by my previous speaker, so I am not going into the details. So it is the atrium paced, ventricle paced, atrium sensed, ventricle paced. So there are 4 types, so I am not going into the details. So mostly the pacemaker preference is a dual mode because it maintains the AV synchrony. So the cardiac output stroke volume is well maintained. So the commonest 59% is the dual mode. Okay. Now coming to this ECG. So you can see how will you diagnose this ECG? You can see the rate is regular, P wave, QRS, everything looks normal. So there are no spikes. That means it is a normal ECG? No, because this is a patient has a good intrinsic rhythm. So the pacemaker is sitting silent and watching the heart rate. So whenever you see a normal ECG, but the patient gives history of any pacemaker implantation, see to that there is a pacemaker, but it is sitting quietly behind and watching the heart. Normal ECG doesn't mean there is no pacemaker. The patient has a pacemaker beneath. If you see an ECG like this, in this, if you see, these are the stimulus. So this is the stimulus, pacemaker stimulus before the P wave. This is before the QRS complex. The rate is around 78 to 80. So it is almost all the complexes are preceded by the stimulus. So it is 100% paced rhythm. And this shows that there are no pauses or any asystole here. So this is 100% paced rhythm, and this is a no intrinsic rhythm is seen. So the patient is a pacemaker dependent patient. Okay. So how can you determine whether the patient is a pacemaker dependent? One thing from the history, if the indication is for a dysarrhythmias, or there is history of AV nodal ablation followed by pacemaker implantation, then according to the Heart Rhythm Society, just the presence of an artifact is not dependence. Only when the pacing burden is more than 40%, or there is hemodynamic instability with the patient's own intrinsic rhythm, or the patient becomes symptomatic when there is sudden failure of the cardiac implantable electronic device, then the patient is called as a pacemaker dependent patient. Okay. So if you want to analyze this pacemaker function, if you have a CIED team, so they are the they have this programmer. So this is the Medtronics programmer. So this is the magnet. This they will place on the patient's pulse generator. Once they place, they will get a rhythm. So what is the rhythm? So what is the set rate, lowest, highest rate? What is the amplitude? What was the mode? Every details you can get. So from this device interrogation, you will able to find whether the pacemaker is functioning normally and whether the patient is a pacemaker dependent patient. If there is a CIED team, you can ask them to gradually decrease the pacing rate and then look whether his own heart is taking up, and look for whether there is any intrinsic heart rate. If there is no intrinsic heart rate even up to 40 beats per minute, or the patients develop any symptoms before that, then he is a pacemaker dependent patient. So what is the significance? Why we should know this? Because before surgery, during the normal time, the patient may have this intrinsic rhythm and he may be pacemaker independent patient. But once he is exposed to the anesthetic drugs, or there is any large fluid shifts or blood loss, he may become a pacemaker dependent patient. So that is why this is more important. So this is the programmer. And actually previously they were using some of the provocative measures to reduce the heart rate, like Valsalva's maneuver, carotid massage, or giving drugs, but that is not preferred nowadays. If you have any doubt, if the CIED team is not available, and if you have any doubt whether the patient is pacemaker dependent or not, then you assume that the patient is a pacemaker dependent patient. Then you can also from the ECG you can analyze set of the pacemaker malfunctions from the ECG. For example, if you are seeing an ECG like this, So this is a failure to pace. Otherwise, the main reason is the oversensing. Here, this is the pacemaker stimulus, the QRS complex. Here, there is no pacemaker stimulus and there is a pulse or asystole. Why? Because the pacemaker senses some intracardiac or extracardiac signals like any electromagnetic interference or muscle contractions. It thinks that as the patient's own heart rate, so it fails to give the impulse here. So this is a oversensing, that means underpacing. Okay. Okay, if you are seeing an ECG like this, so here, as I already told, you have to see whether every pacemaker stimulus is followed by a contraction. Here you can see this is the pacemaker stimulus, but there is no ventricular contraction here. So that means that is failure to capture. So there can be so many reasons, like it can be a loose connection, or it can be electrolyte disturbances like hyperkalemia, whatever it is. So the treatment should be, you have to increase the pacing threshold in these patients. What is this? So this is a pacemaker stimulus. So this is a QRS complex, and here you can have a normal stimulus. But whenever the pacemaker senses a normal stimulus, it should not give its own impulse. But here you see, this is the pacemaker stimulus, and that too lying on the refractive period of the ventricle. That is the R on T phenomenon. So that is very dangerous. That can precipitate life-threatening ventricular arrhythmias. So this is a undersensing. So this doesn't sense there is a intrinsic beat. So you have to increase the sensitivity of the pacer in this type of patients. Next is the inappropriate rate. So some of the pacemaker, by sensing the stimulus from the other ventricles, so it can pace at a rapid rate. So this is a pacemaker mediated tachycardia. So there is another terminology called runaway pacemaker. So this is mostly seen when there is an aging pacemaker where there is any leakage. Here the rate is very high, that is more than 180, 200, and it can be very lethal. And immediately the patient should be changed to the asynchronous mode, or a temporary pacing should be done, and the pulse generator should be changed. So, but what is the difference between this PMT and runaway pacemaker? In pulse pacemaker mediated tachycardia, usually the rate doesn't go beyond the set rate. Usually they will set a lower rate, for example 60, and a higher rate 130. Here it doesn't go beyond that 130, but here the rate will be very extreme, more than 80, 200. Okay, so this is the pulse pacemaker mediated tachycardia. Okay. Now let us see, next is important thing is what are the magnetic applications on a pacemaker. So whenever you place a magnet over the pacemaker, it will trigger the reed switch. So this is the reed switch. When it gets triggered and closed, the demand mode will be switched to the asynchronous mode. That is a fixed rate. It will deliver a fixed rate. So for this, how much magnetic field should be needed? That is more than 10 Gauss is needed to activate this reed switch. So here you can see, so this is the normal rhythm of the patient. Here we are placing the magnet. After that, it changes to this asynchronous mode at a fixed rate. Okay. Okay. Now, so two things you have to know in this. One thing, this magnetic application, we cannot be sure that this is the same in all the models. So it can vary depending upon the manufacturers. One thing, if you apply the magnet on the pacemaker, it will be converted to the asynchronous mode. Second thing, if the patient is having an ICD, placing the magnet over the ICD will terminate only its tachyarrhythmia detection and anti-tachycardia function, and not the pacemaker function. So for the patient with an ICD, you have to reprogramming only should be done. And certain manufacturers also have the advantage of you can hear some audible tone when it changes to the asynchronous mode. From that you can identify it is in the asynchronous mode till the beep sound is heard, like Boston and St. Jude. On removal, converting it to the previous rhythm, the tone will cease. So this is an advantage. So from the sound you can make sure that it is still in the asynchronous mode, especially during the intraoperative period. But what is the disadvantages of this asynchronous mode? One thing, if the patient is a pacemaker independent patient, that is, he is having a normal intrinsic rhythm. So this changing to the asynchronous mode, what will happen? It will, as I already told, If the stimulus falls on the refractory period, it can lead to an RNT phenomenon and ventricular arrhythmias. Okay. So this is a picture showing first how to place the magnet. First, you have to palpate the edge of the pacemaker and mark it with a marker, and then place the magnet exactly over that and tightly tape it with the adhesive plaster. There should not be any gap between the magnet and the skin. So like that only you have to fix the magnet during the intra-op period. Okay. So during the magnetic applications, you have to take a ECG before the applying the magnet and also after the magnet is removed to make sure it is changed to the asynchronous mode. So for example, if you are seeing no changes in the ECG, means that you can think of one thing, your position is not correct, or there may be a depleted battery. Third thing, the pacemaker is programmed to ignore the magnet. Fourth, the patient is very obese so that the depth doesn't reach till the pulse generator. So you may need in obese patient, you may need to place 2 magnets. Okay. Next, you are coming to the preoperative preparation. So how we are going to prepare this patient? Coming to the investigations, you have to do depending upon the surgery. So the routine investigations you have to do. And the most important thing is the serum electrolytes, because the potassium level mainly determines the resting membrane potential. So any changes in the hyperkalemia or hypokalemia, so it can affect the patient's threshold. So you have to optimize the serum electrolytes if it is not normal before surgery. Then these patients are maybe on anticoagulants. So you have to do a basic coagulation profile. And you have to ask the patient to continue the drugs. They may be on antiarrhythmic drugs. Ask them to continue the drugs till the day of surgery. Then you have to assess what is the indication. Now you would have known what is the indication the pacemaker was kept. So what is the current functional status of the heart? So that is done by means of a dobutamine stress test if needed, because only there is the chronotropic, that is only if the patient is asked to do a treadmill, that is not possible if they have an asynchronous mode or a fixed rate. But by giving dobutamine, the contraction of the heart, that is not affected. Only the inotropic effect is not affected by the pacemaker. So you can detect any regions of ischemia by giving this dobutamine stress test. So checklist, what and all you have to do. Now you have done the investigations. So in the preoperative period, you have to discuss with the surgeon. So what is the type of surgery? So whether it is a major or minor surgery, where they are going to do the surgery, whether it is above the umbilicus, thoracic or upper abdominal surgeries. Then patient positioning, because if the patient is in the lateral or a prone position, placing the magnet may be difficult. So that time you may need a programmer to reprogram the device. Then you have to determine whether there is any electromagnetic interference will be there. Then what are the anticipated post-procedural arrangements? For example, whether the patient is going to be discharged as a daycare or he is going to be an inpatient. The next thing is whether this pacemaker has to be converted to the asynchronous mode, or the rate adaptive function should be disabled. Then check whether this OT has all the temporary pacing methods and defibrillation and emergency drugs, atropine, isoproterenol, everything is kept ready. And the OT personnel are trained in handling the emergency situations. And then you have to plan your anesthesia technique. Okay, is reprogramming is required in all devices? Then it is a big no. First, the surgical procedures where there is high incidence of electromagnetic interference. Second, if the patient is a pacemaker dependent patient. If the surgery is going to interfere with the site of the pacemaker implantation. Fourth, the patient is having an ICD, that is rate adaptive features. Then you have to change the pacemaker to the asynchronous mode. Otherwise, there is no need to reprogram. Okay, so this is the CIED team, the CIED, the programmer. They will be doing a device. If they are available, they can do the device interrogation, and they will be giving these essential, like what is the rate, what is the magnet set rate, what is the rhythm, what is the heart rate for shocking, and whether removing the magnet will automatically change the pacemaker to the previous mode. And all these details they will be providing to this operating team. Now coming to the electromagnetic interference. So the electromagnetic interference in a OT is mainly because of the electrocautery or the diathermy. So you should know whenever the frequency waves in the range between 0 to 10 power 9 and microwaves in the range between 10 power 9 to 10 power 11 mainly causes electromagnetic interference. So the high frequency range like X-rays, gamma, infrared, we need not bother about those things. So only this frequency will cause this problem. So whenever you are using this electrocautery, so this monopolar is more dangerous than the bipolar. Why? Because the monopolar current is perceived as an aberrant cardiac impulse. Here you can see in the monopolar, the current is passing through the body from the anode to the cathode. So it will be detected by the pulse generator as a patient's own heart rate, or as it can be considered as a arrhythmias. Whereas in a bipolar, the current passes only between the two ends. So that is why monopolar is very dangerous. So what are the things can happen to the function of the pacemaker when exposed to EMI? One thing, it can cause inhibition of pacing, or it can reset to the factory mode. It can cause myocardial burns. It can sense this electromagnetic interference as arrhythmias. It can deliver a shock leading to burns and inappropriate tachycardia. So that is why we have to do certain precautions when there is electromagnetic interference. So what are these precautions? One thing, as I already told, bipolar is the safest mode. If not available, if the unipolar cautery, the grounding plate should be placed close to the operative site, and the electrocautery should be more than 15 centimeters from the pacemaker. To ask the surgeon if the ultrasonic or harmonic scalpel is available, it will be better if they use that type of mode of instruments, and ask the surgeon to use a short burst of electrocautery, that is less than 1 second for every 10 seconds apart, because when you are using it shortly, this prevents the repetitive asystolic period. Then the lowest possible current should be used by the surgeon. Recently, we have also many shields developed to protect the pacemaker pulse generator made up of titanium. So you can also use that prevents from noise interference and also from the electromagnetic interference. And you have to keep the basic temporary pacing pads, defib pads, everything should be kept ready, and also the emergency drugs should be kept ready. Then coming to the intraoperative monitoring. So depending upon the type of surgery, we will be using the monitoring. So almost apart from the routine monitoring, so certain important points you have to remember while using this ECG monitoring. So one thing is the artifact filter in the ECG should be disabled because it may detect this pacemaker stimulus as an artifact. Next thing, you have to change the ECG to the pacing mode. Why? Because otherwise it will cause double sensing. It will sense both the pacemaker stimulus and as well as the contraction as 2 beats, and so it will show a very high heart rate. Third thing is we can increase the size of the complexes so that we can easily identify this pacemaker stimulus. If it is very small, means we cannot, sometimes we may miss the pacemaker stimulus. Next is a vigilant anesthetist with a pulse on hand is a must to look for the peripheral perfusion. So it is monitored by pulse on hand or by means of a precordial stethoscope or pulse oximetry. And in case of a major surgery that there is you expect a large of vascular surgeries, increased blood loss or large fluid shift, better to have an arterial line, and invasive arterial monitoring is a must. And coming to the CVP, better you choose the sites other than the pacemaker sites. You can choose the lower limb like femoral vein for a CVP monitoring if it is a major surgery that needs the CVP monitoring. Then coming to the anesthesia technique. So the anesthesia technique per se doesn't directly affect the pacemaker function, but the physiological changes, whether it is an electrolyte imbalance or acid-base imbalances or the fluid shifts or the blood loss, that can affect the CIED function. For example, in a spinal anesthesia, because of the spinal hypotension in a normal patients or the patients who have a rate adaptive response pacemaker, so it will compensate by means of reflex tachycardia. But here, after changing to the asynchronous mode, this compensatory tachycardia doesn't happen. So you have to optimize the patient with adequate fluids, and you have to maintain the hemodynamic stability. Next is coming to the general anesthesia. So general anesthesia, there are certain things you have to remember. One thing, in the pre-medication, so the drugs, certain drugs we use, they can have effect on the SA node and AB node, and they can increase the pacing rate, like the opioids, dexmedetomidine. So all these can increase the pacing rate. So you have to titrate or avoid certain drugs. Next important thing is the certain drugs we commonly use just is the before surgery is the anisette or the ondansetron. So this can cause QT prolongation. So better to avoid these drugs, unlike haloperidol, methadone, all this can cause QT prolongation. Third, coming to the induction, so the drugs mainly the etomidate and ketamine, they can cause myopotential interference by causing myoclonus. So better avoid these drugs. You can go for a thiopentone or a propofol. Coming to the relaxing agent, as we know, scoline causes fasciculations, thereby leading to muscle contractions that may be sensed by the pacemaker as a stimulus. So you have to avoid scoline, or you can use a defasciculating dose of the non-depolarizer before giving the scoline. Then there are certain factors that can affect the pacing threshold. So you have to intraoperatively avoid these factors. As I already told, this hyperkalemia, hypokalemia, then hypothermia, hypoxia, hypercarbia. So all these things can affect the pacing threshold. So you should be careful in avoiding these factors intraoperatively. Then coming to the nitrous oxide, as we already seen, this nitrous oxide is avoided in a recently implanted pacemaker because it will cause expansion of the air packet and can lead to lead dislodgement. Coming to the volatiles, almost all the volatiles in higher concentration, they can cause long QT syndrome. So better to use it judiciously and titrate the concentration. Then maintain normothermia and avoid shivering because of the same reason as I already told above. And in a case of major surgery where you expect large blood loss, better you ask the programmer to set the pacing rate at a higher level. Then OT should be ready with the defibs and the temporary pacing pads. And while pacing this temporary pacing pads, it should be fixed 15 centimeters away from the edge of the CII ED and in the antero-posterior configuration. The shock should pass perpendicular to the CIED leads. So this is the position of the paddles you have to place. Then what will you do if there is some intraoperative mishaps like an arrhythmias? So one thing, first you have to ask the surgeon immediately to stop the surgery, stop all the electromagnetic interference, and then remove the magnet from the pulse generator. So this will automatically revert to the previous rhythm. Observe whether it is reverting to the previous rhythm within 10 to 12 seconds. If it is failed, then you have to go with the external temporary pacing pads or the external defibrillation and resuscitation according to the ACLS protocol. Okay, if the patient goes in for a pacemaker, sudden pacemaker failure. So the treatment depends upon what is the BP. So whether the rate is adequate to maintain the BP, or there is severe bradycardia or hypotension, or there is no rhythm. Based on that, we will be, apart from the airway control and oxygen, we will be using this atropine and isoproterenol, and then place the magnet over the pacemaker. So that to convert it to the asynchronous mode. If it is not working, then go for other types of pacing. If there is no rhythm, immediately you have to start the CPR, and according to the ACLS protocol, you have to proceed. Then coming to the post-operative care, the post-operative care, the continuous cardiac monitoring. So the rhythm, rate, everything should be continuously monitored, and avoid post-operative shivering or fasciculations. And if the patient is in mechanical ventilation, they have, theoretically, they say there is a risk of lead displacement in a case of IPPV. So better you have to check the pacemaker function after the patient is weaned from the ventilator and before shifting to the ward. And in the ICU also, you have to keep ready all these pacings and the defib equipments and all the emergency drugs. So there are certain recommendations for the device interrogation should be done before discharging the patient from the ICU. So what are the recommendations? One thing, if the patient underwent any hemodynamically challenging surgeries, any major cardiovascular surgeries, definitely device interrogation should be done before shifting to the ward. Next, whether there is introp mishaps have happened. Third, whether the patient underwent procedures that emit greater probability of the electromagnetic interference. Fourth, if the device was reprogrammed before the procedure. So all these cases, you have to do a device interrogation before shifting to the ward. So these are some of the special situations that is outside the OT. For example, if the patient is going for a radiation therapy, definitely this high energy ionizing radiation can cause damage to the pulse generator. So if possible, we can relocate the pulse generator to the opposite side. And in these patients, definitely it should be evaluated weekly. If it is a lithotripsy, you keep the lithotripter 6 inches away from the pacemaker, and the beam should not be focused near it. And the lithotripter pulses should be timed with the ECG, and definitely you have to change to the asynchronous mode. And ECT, even though the current is given for a brief period of just 5 seconds, the post-shock seizures and the electrolyte imbalances can interfere with the pacemaker. So you convert it to the asynchronous mode in these patients. TENS, definitely you have multiple electrodes giving pulses of 200 volts in this much hertz. So better change to the asynchronous mode in these patients. And MRI safe devices, you can proceed. In a case of MRI non-conditional, better it is a contraindicated. And defibrillation, as I already told, antero-posterior position and 15 centimeters away from the pacemaker edge. And TERP, usually lower arm surgeries below the umbilicus. When the electromagnetic interference is more than 15 centimeters, there is no need to change the mode to the asynchronous mode. These are some of the special scenarios. Okay, so coming to the final summary. So if you are having a patient with a pacemaker, first you see whether there is electromagnetic interference and whether the surgery is above the umbilicus. If it is no means, then there is no need to reprogram or place the magnet to change to the asynchronous mode. Just keep the magnet available in the theater. If yes, there is electromagnetic interference or the surgery is above the umbilicus, then you have to see whether he is a pacemaker dependent patient. If he is a pacemaker dependent, yes, then you have to definitely place the magnet or reprogram to the asynchronous mode. Not a pacemaker dependent, then you keep the magnet available. But if there is a chance of electromagnetic interference less than 15 centimeters, then you have to do the magnet application or reprogramming. Okay, now if the patient is having an ICD, definitely if there's an ICD, you have to deactivate the ICD. Then see next whether the patient is a pacemaker dependent. If he is pacemaker dependent, then you reprogram to the asynchronous mode. If not, then no reprogramming is necessary. So this is the emergency protocol. You have no time for any evaluation. Landing up as an emergency case, you just take a 12-lead ECG and see whether he is a pacemaker dependent patient. Yes, he is a pacemaker dependent. Place the magnet over the generator, ask the surgeon to use short burst of electrocautery. If he is having an ICD, just place the magnet to deactivate the anti-tachyarrhythmia function, and better you call for the until the reprogrammer comes, you ask the surgeon to use a short bursts and monitor. If no means, if it is a pacemaker, just keep the magnet available. And if it is an ICD, you have to place the magnet and convert and switch off the anti-tachyarrhythmia function and call for the reprogrammer. And until then, you ask the surgeon to give short bursts. So evaluate the device always prior leaving the telemetry. So with this, we have completed this topic. So in the summary, so as I already told, so the evaluation, so the teamwork, mainly the multidisciplinary approach, the teamwork between the surgeon, anesthesiologist, and the CIED team. So that is more important. So because one single technique is not suitable for all, it is a we should frame an individualized plan for each patient depending upon their cardiac condition. What is the type of pacemaker? You should know about the magnetic effects, whether the device will respond or not. Then you have to frame your anesthesia management, then how to monitor the patient depending upon the surgery, major or there is blood loss, regarding invasive monitoring is needed. Then how to protect against this electromagnetic interferences, and what are the emergency pacing and defibrillation things you have to keep ready, and how you are going to monitor the post-operative monitoring this patient, and how the post-operative when you have to do the device interrogation while before shifting to the general ward. So these are the things you have to keep in mind. Okay. So with this, we will finish the topic. So mostly I have taken this from our standard textbooks. And thank you so much for the patient listening. Thank you.
Thank you very much, Dr. Narmata. It is an excellent lecture. You covered completely about the pacemaker and anesthetic implications. It was a very good depiction of X-rays and ECGs. It's very useful to the delegates, I think. I have learned a lot because
Thank you, sir.
We have used more than 20,000 pacemakers in our Meenakshi.
Okay,
But
sir.
I have learned a lot from you. Thank you very much.
Thank you, sir.
Excellent lecture. But you covered from pre-op evaluation, intra-op monitoring, including that what all monitors, about the drugs, and post-op what all measures to be done, pacemaker failure, everything you have covered. Okay. Perfectly covered. And I think some of you, maybe some of cardiologists in your family may be there, but that helped a lot to collect all the information about the pacemaker, all interrogation device, everything you got it. Thank you very much.
Thank you,
excellent,
sir.
Excellent coverage of materials.
Thank
We'll
you,
move on to the discussion part.
Okay, sir.
There are a lot of questions that too, especially from our academic chairman as usual. I think we'll take up the questions from the chat box and then we'll have further discussion if anything, including interventional cardiologist. Okay, she has taken a lot of material from the electrophysiologist, I think. Is there a lead if there is a lead migration or the patient complaints of hiccup or abnormal hand movements, will you proceed or postpone? In an emergency, what will you do? That is the first question.
Okay, sir.
There is a lead migration, what will you do?
Sir, so right, actually, if it in case of an emergency, we cannot actually postpone the patient. So one thing, depending upon the surgery, as I already told, if the surgery is below the umbilicus and there is no electromagnetic interference, definitely we can proceed with the surgery, sir, without taking time to asking the reprogrammer to replace the device. So if there is a chance of electromagnetic interference or a surgery is above the umbilicus, then we have to keep the emergency temporary pacemakers and defibrillation pads and proceed with the emergency surgery. For that, we cannot postpone the emergency surgery. But if it is an elective, then we can actually ask them to reprogram and replace the device, and then we can follow.
Yes, perfect. If it is elective, as you said, we can reposition the lead, or we can put a temporary pacemaker and then proceed. Depends upon the situation. And if it is emergency, we cannot wait. We have to proceed with the temporary pacing and then proceed for a surgery. Does it okay, sir?
See, the chairperson has to give the decision.
No, that's what. That's what.
Yeah, I don't know anything I asked her just because.
Elective, we have to reposition the lead.
That's
and
right.
In emergency, we can proceed, and if at all, we can take a temporary pacing, and then we can proceed.
I have asked so many questions because she has given the food for thought.
Yeah, definitely.
But the surprising fact is, in spite of being my student, how she has become more knowledgeable, I don't know.
She has to.
How that is possible, I don't know.
Will you able to change the sensitivity of the implantable pacemaker if there is R&D phenomena, or you need the help of pacemaker technician?
Sir, if we have the programmer and the Medtronic programmer device is there, we can change the amplitude, sir. So without the programmer, or you should be well trained in reprogramming the device with the programmer. Otherwise, you have to call the reprogrammer.
Yeah,
Yes.
that is my specific point. So when the programmer is not there, what you will do? So whenever you are planning, you have to have the programmer by your side, and in emergency, what you will do? That is the point.
So one thing, this RNT phenomenon happens only we change the patient with the intrinsic rhythm. When we change to the asynchronous mode, this is a more dangerous thing. So that is why when the patient is not a pacemaker dependent patient, that means his rhythm is good, we need not change to the asynchronous mode. So only when with intrinsic rhythm, changing to the asynchronous mode can cause this RNT phenomenon and leading to dangerous arrhythmias. So if he is maintaining a good rhythm with a good rate and maintaining the BP and hemodynamic stability, then we need not change to the asynchronous mode.
Madam, I want to take home message for the youngsters.
Okay.
If there is a RNT phenomena,
Okay, sir.
when you are anesthetizing a patient, when there is a RNT phenomena, you cannot do anything with the pacemaker on your own. Am I right or not?
Correct. Perfect, sir.
Yes, sir.
Right.
Yes, sir. Yes,
Then
sir.
it's okay. And then we
Yes,
go
sir.
on next
We
question.
cannot program anything. We cannot do anything at the time
Yes.
when there is RNT phenomena. When there is an RNT phenomena, it produces fibrillation. We have to shock the patient, or it goes to the tachyarrhythmia mode. We can put a magnet and we can proceed with the asynchronous mode, or we can go with the TPA mode. So the usual thing is we cannot do any programming. If it is RNT phenomena producing fibrillation, we can put a shock and then proceed with the same mode. And if the mode is changing over to asynchronous mode, continue with the asynchronous mode and proceed with the surgery. And then in the post-op, call for a programmer and reset the TPA. That is what we have to do. This is a good question. Whether anesthesiologist can use mobile when patient has pacemaker, whether any mobile compatible pacemaker is available like MRI compatible.
Sir, actually MRI compatible means it's also it's compatible with the mobile, sir. So actually, according to the latest FDA, if it is MRI compatible means we can use the mobiles. That
So you
doesn't
are
interfere
using
with
mobile,
electronic.
madam. When you are anesthetizing a patient, whether you are using mobile inside the theater?
Yes, sir, you'll be having the mobiles.
I am very sorry to say,
sir,
whatever may be the case, that is when whatever may be the case, anesthetist should not engage with the mobile.
Sir, we'll be having the mobile, sir. We know we won't be actually looking at the mobile or engaged with the mobile, but
So
definitely the mobile we'll be having the mobile in our packets.
The usage should be prohibited.
Yes, sir.
Yes, sir. Unless it is an emergency, better not to use any mobiles inside the OT during
intercoms. Emergency, it is only
intercoms. And mobile devices will not interfere with the pacemaker. If at all it is used 15 centimeters away from that. That too, all digital mobile interfere with pacemaker.
Chairperson, sir, it is not interference with the pacemaker. It is interference with the anesthetic concentration. That is anesthetic concentration.
That is different. Regarding this question, definitely all digital mobiles interfere with the pacemaker. And currently there are MRI compatible and mobile compatible pacemakers are available. So these things will not be a problem, but better to avoid. The next question is, if the pacemaker is failed, then why magnet over the pacemaker? Namrata madam, you have mentioned that in pacemaker failure, put a magnet and proceed for surgery.
Yes,
the pacemaker is failed, why magnet over the pacemaker? It is not that meaning of pacemaker failure and you have to put a pacemaker. It is a pacemaker malfunction. In that situation, you can put a magnet and make it to asynchronous mode. Okay. That is the correct version.
Okay.
The pacemaker is completely failed. There is no use of a pacemaker. And we have to go for, depending upon the rhythm, if the patient is completely dependent on pacemaker, the rate is below 40, below 50, then you have to go for emergency temporary pacing.
Temporary pacing. Okay.
Yeah, good, yes. Perfect. So it is not failure, it is malfunction. In that situation, the magnet is useful. If it is failure, TPA is useful.
Okay. Okay.
And next one is whether CPR could be successful in pacemaker failure. The same answer. CPR whenever there is a pacemaker dependent patients, in that situation, CPR doesn't mean that compression, that if you are not able to increase the rate by conventionally available drugs, you have to go for emergency temporary pacemaker. Either you are having the options to go for transvenous pacemaker, well and good. If you are not having the transvenous, the safest way is go for transcutaneous. That will be a very safe one to save the patient at that time.
Okay.
And then next question is, the pacemaker site is infected with the pus and surgeon wants to remove the pacemaker. What will be the anesthetic technique? Usually it would be an emergency, and when replacement is not available, what is the management?
Sir, usually we'll do it under a TIVA, and just an IV anesthesia is adequate to remove the pus. But here also we have to keep the temporary pacing ready, sir. As we have to remove the pacemaker until we have to replace with a new pacemaker, we have to be on a temporary pacemaker if he is a pacemaker dependent patient with a very low rate, sick sinus syndrome and all like that. So the cardiologist has to do with a transvenous pacing, and then they have to replace with the pulse generator.
Yes. When the site is infected, better we can remove that pulse generator, allow that pocket to heal. Till then, the management is TPA. We won't go for emergency PPA again. We'll go for temporary pacing. We'll maintain the patient with the temporary pacing. And then for that, the anesthesia is already, she has mentioned about a lot of drugs. In that, ketamine, etomidate, fentanyl, so many normally conventionally used drugs should be avoided as far as possible to prevent that pacemaker malfunction. If you are going for removal of the pacemaker, there is no question of malfunction. You can use any drugs and can save the patient with the TPA. So that is a question. Anesthesia, there is no interference if you are removing the pacemaker. Number one. Number two, TPA is a way to go for saving the patient at that time. Once the pocket is clear and infection is settled down, then only you have to plan for the elective permanent pacemaker on the other side, or that there is not possible, then you can go with the same side also. Okay. That's about questions. Is there anything, any other questions, sir?
Yeah, 3 of my questions are not answered.
What, sir?
If there is no pacemaker card with the patient, then how would you proceed?
So that's what I told. We can take an X-ray. So simple X-ray will give you all the details about the pacemaker, and then equally ECG will help you to know about the pacemaker mode and functioning system.
Even the X-ray gives information about the programming.
No, sir.
No, sir. It doesn't give us the programming.
These are all the take-home messages. These are all the take-home messages. That's what.
Yes, sir. There is no pacemaker card. Obviously, even if there is a pacemaker card, you have to confirm with the X-ray and ECG. History very clear. History about the placement of pacemaker. History about the card they are having, and then indication or situation why they went for that procedure. The symptoms relieved after pacemaker. All those things related to the history, and then we have to confirm with the ECG and X-ray.
Then the previous speaker said the phone is to be kept mobile phone, that is 6 to 12 inches away. That means whether they have to talk in a speaker mode, that is when the patient is anesthetized, there is no point, the patient is not going to talk. But I want to know what is the significance of Bluetooth and wired earpieces, whether there is any difference in interference, Bluetooth or wired connectors.
There is no literature evidence for Bluetooth or wired, but as far as possible, literature says that you should keep 15 centimeter away from the pulse generator. So in that situation, better not to use with your conventional usage of mobile phones. Better to use either wireless earpieces or wired earpieces that will not interfere with the pulse generator.
If the patient complains of hiccup or abnormal hand movements at the time of surgery, before surgery, whether you will proceed or how do you manage?
Yes, sir. It's a very good question. But hiccup and abnormal hand movements all related to lead displacement or irritating the diaphragm. So in that situation, we have to confirm that lead placement. If the lead is dislodged, better. If it is elective, reposition the lead and proceed for procedure. If it is emergency, put a temporary pacemaker and put a magnet over the permanent pacemaker and then proceed for surgery.
So in a nutshell, if a patient is coming with a pacemaker, the anesthesiologist should be competent enough to insert a temporary pacemaker.
Yes, sir. 100%. 100%. For that, previously we are more dependent on transvenous. Now transcutaneous works out very well. So since there is an pulse generator already placed on the left pectoral, usually better to put a anteroposterior placement of paddles, like in the apex one and then left scapula or right scapula, whatever the position, no problem. Anterior posterior placement of paddles can go for straight away. All conventionally available machines are having the pacer mode in our defibrillators. So we can use the transcutaneous pacing as an excellent method for solving these problems.
Excellent, but I should congratulate Dr. Narmata. She has covered extensively well. She has covered everything. But
very good.
Only problem is she is talking in a language which could be understood only by Dr. Kumar.
No, not like that.
Not as a lay person like us.
No, sir. Everyone should know about this.
So it is good. It is good. No doubt.
Yeah,
Absolutely no doubt. Many people are asking whether we can have a recorded version right now. I assure tomorrow everyone will be get a recorded version.
Yeah, it is very useful for everyone. So definitely.
Many people are asking. So yes, that is also another development in this lecture.
There are a lot of congratulations and asking about the lectures. Very good. Thank you very much, madam. Beautiful coverage of.
Thank you, sir. Thank you so much for your guidance, sir. Yeah.
I think we have covered everything, sir. The most important thing is like what you said is about the monitoring. In drop, we are putting magnet, all those things everybody knows. In that ECG monitor, many of them not putting that diagnostic mode, always putting on monitoring mode. So please change it to diagnostic mode. That will detect the artifacts as well as basic spikes, all those things. Number two, artifacts switched off many times. So that should not be done. So artifacts should not be switched off. And this one should be put it in a diagnostic mode instead of monitoring mode ECG. And many a times we are forgetting to put a hand on the pulse. In this particular situation with the pacemaker, put a hand on the pulse. Always confirm with the pulse whether there is transmission of electrical activity. And number two, if there is a possibility, there is a need or possibility for invasive lines, better to go with invasive lines to make sure that the asynchronous mode or the pacemaker is functioning well and the patient is having adequate electrical activity and cardiac output and generated blood pressures. This is most important thing because everybody knows about the nomenclature, but in drop many a times they were in an emergency situation to handle that because many of the things missed by not adequately monitored in a situation without noticing that pacemaker is not functioning. Electric activity, the electrical activity will come on the monitor, but they will not notice that it is artifacts. So those things has to be cleared by putting a hand on the pulse, our conventional old techniques, and also if possible in invasive lines. That is very good. Invasive lines for all major surgeries we are doing. For minor surgeries we are not doing. For that we should not take it. That all pacemaker coming for anesthesia and surgery is a major procedure.
Chairperson, sir, two questions left out. One
yes,
is, sir has asked whether the patient is having a AICD, whether he can use mobile or not. Another question is how to check the battery life of the pacemaker.
Yes, sir. Just first question: how to check the battery life of the
pacemaker?
That is yes. If you have this,
please, madam.
So if you have this programmer, we can connect to the device Medtronics depending upon the company. So it will give you all the details regarding the battery life, everything.
So again, programmer.
Or other thing, or if the patient's rate is at least 10% less than the already what is the fixed rate. So from the basic rate, if it is more decreasing more than 10% from the basic rate, means there is some battery depletion is there.
But it is not concerned with the amplitude, madam. It is only the rate or the amplitude also counts.
Amplitude also counts, sir. Both amplitude and rate will decrease by 10% if it is started depleting. But that is not a matter, sir, because only by programmer integration, only we can definitely say that the battery is going down.
Because another participant,
all other things are, yes, sir.
As a corollary, another participant has asked when
Yes,
the patient can feel that the pacemaker is not functioning and when he should go for replacement. The same, it is only, the question is a corollary. The patient would have been tutored by the programmer and the cardiologist when to come for a checkup and when to do that. So a patient cannot do it on his own. He has to consult a doctor whenever there is a failure. And when AICD is inserted, can the patient can use mobile phone?
You can use, sir.
No, sir.
No, we can use nowadays AICDs, we can use mobiles, but the same distance has to be maintained. That's it.
Dr.
Not interfering with the shocks.
Dr. Sarpabu Chavuru asked this question. I
Yes,
think we have answered all the questions.
Yeah.
Any other questions? For AICDs, magnet places. The purpose of magnet is just to prevent that antitachycardia.
Antitachycardia.
Otherwise, the pacing will work and everything will continue. Only antitachycardia function, and magnet placement is better than programming, because whenever there is a fibrillation during surgery, you can remove the magnet, immediately the shock will be given by the pulse generator. So patient will be even before you take that defibrillator and shock the patient, that machine will take care of the shock. So magnet is a better choice whenever there is an AICD going for surgery. So if you put a magnet, it will prevent antitachycardia function alone. Pacing will work on, and there is a defibrillation, there is a fibrillation or tachycardia during the procedure. If you take out the magnet, it will solve the problem. It will immediately solve the problem. So if it is not getting solved, you can give the external defibrillation. That's about. Any other questions? Any other questions from Dr. Suresh? Sir,
I want to ask one question.
Yeah, please, sir, please.
Yeah, if a pacemaker is perfectly working and we have to take a case as a medical legal setup without
Yes,
backup, transcutaneous or transvenous, you should not take the case. You can take a take-home message, sir.
Yes.
Perfect. Even with a perfect pacemaker.
I couldn't get you. I couldn't get your.
Chairperson, sir, he is asking,
yes, sir.
With a patient with a good functioning pacemaker,
yes, sir,
in a place where temporary pacer and transcutaneous pacer are not available.
Yes, sir.
Medico-legal aspects, whether he can refer the patient somewhere, or without that, whether he can take up the case. So he is asking medico-legally. Medico-legally, definitely no. You should have a backup. Medically,
no, sir.
Definitely no. You should have a backup.
Perfectly
anticipated. It is anticipated. When an expert, see, when there is a problem, medico-legally answer, when there is a problem, an expert witness will be called. He will be questioned. Without a backup, can you proceed? So the expert will be only people like Dr. Kumar or Dr. Narmada. They will bluntly say, you cannot proceed. At least if a person like me comes, I can say we can try because there is a problem, emergency, remote setup, so many things I can say. But experts like them, bluntly, they will say you cannot proceed. So don't venture.
That is what, even perfectly functioning pacemaker, without backup, you cannot proceed, sir. And you cannot say in the court of law.
Okay, thank you. Thank
you. Is there any other questions? I think she covered everything, sir. That's why people are very happy with not asking much clarifications.
Right. So
we can conclude, sir.
Yeah, shall we take over, sir, from you?
Yeah, okay, sir. So thank you very much, Dr. Narmada and Dr.
Thank you, sir. Thank you so much, sir, for your
Chandrakala and
guidance.
Shweta for the excellent lectures, and completely covered about the conduction system, functioning, pacemaker functioning, and pacemaker and anesthetic implications. It is completely covered, and everybody should know about the nomenclatures and pre-op evaluation, inter-op monitoring, and post-op how we should have the backup. Most important backup in the post-op is interrogation of the pacemaker, and then defib and temporary patient should be there whenever the patient is on pacemaker. Without that, we cannot justify anywhere. So with this, thank you very much for all the speakers, and thank you very much, Dr. Academic Chairman Dr. Meena Sundara sir, Dr. Perisami, Dr. Suresh Kumar for the opportunity. We had a great discussion and great evening. Thank you very much.
Thank you,
Thank
sir.
you, sir.
Thank you, Chairperson, sir. Before I hand over the session to President, I personally thank Dr. Kumar, Dr. Narmada, Dr. Chandrakala, and Dr. Niveda, and I request Dr. Narmada and her team to please write up an article of this pacemaker, because really you have covered extensively well. So that will be a testimony for your hard work. So all the three people, you can write a book, just 20 or 30 pages. We can circulate it, and we will take care of that, because it is extensively covered, well covered. So I request all the three to sit together and write it in lines with your PowerPoint. That is my personal request. Now I hand over the session to President Dr. Suresh Kumar.
Thank you, sir.
Thank you, sir.
Thank you, sir.
The session went very well, very pragmatic, with a huge attendance. I thank all the speakers, and especially our chairperson and president of state ISA, Dr. Kumar, who wonderfully shared all his experiences this session. This is the Thanksgiving time, and I call upon and request Dr. David, our treasurer, to host the vote of thanks. David, please.
Sir. Good evening. Good evening to all. On behalf of ISA Pudukkottai, first of all, I would like to thank our chairperson, Dr. ALM sir, for arranging a wonderful academic session. And I would like to thank our chairperson, Dr. Kumar sir, President ISA Tamil Nadu, for sharing his wonderful experiences. I also extend my thanks to our speakers, Dr. Narmada ma'am, and Dr. Chandrakala and Dr. Niveda, for excellent academic session. And thank Dr. Suresh Kumar sir, President ISA Pudukkottai, Dr. Perisami sir, Secretary ISA Pudukkottai, and other faculties, postgraduates, and our sponsor Accurala and A1 Logics for successful Pudukkottai Budan event. Thank you. Thank you, sir.
Thank you, sir. Thank you.
Thank you, sir.
very much, sir.
Thank you. We can conclude the meeting.
Thank you, sir.
Thank you, sir. Thank you, sir. Thank you so much.
Thank you, ALM sir.
Thank you.
Thank you.
Thank you, Chairperson. You are chairing Tamil Nadu.